Sorry, there was a short of some interruption. I was trying to continue with the cord prolapse. At definition, I said a cord prolapse occurs when the loop of a umbilical cord slips over in front of the presenting part and the membranes have ruptured. And you are saying basically diagnosis of the cord prolapse is done through vaginal examination after the membranes have ruptured, where it is failed, where you can be able to feel the cord in the vagina, or you can be able to see the umbilical cord at the vulva. Therefore, once this cord has been seen in the vulva, or it's seen outside the vulva, there is always deceleration of the vital heart rate during the auscultation. Management. As a student, you must be able to know how to manage this mother with cord prolapse. As a qualified midwife, you must be able to know about the management of this one. So number one, we are saying shout for a medical aid. And how to shout for a medical aid? Just shout cord prolapse. Then the medical aid, they will come and assist you in management of this mother. The other one we are saying, try to use the word if during in your management, so that you can be able to manage properly this mother. So number one, we are saying, if the mother she's on oxytocin, stop the oxytocin drip, so that you can be able to relieve the cord from being compression. If the cord is visible at the vulva, clean it with a warm normal saline, then try to replace it inside the vagina, or to maintain the warmth and also to prevent the spasms and also to prevent the cord from drying. Administer oxygen to this mother, that is humid oxygen by mask. We are saying 4 liters per minute, and then they start the mother on IV fluids. That is, you can begin with the lactate, Riga's lactate. You can use the Hartmann solution, or if they are absent in circumstances, you can also use a normal saline. You also need to give this mother salbutamol, that is tocolytic, so that you can be able to relieve a contraction from this mother. Then the other things we should be able to appreciate as a midwife is, what are the ways that you need to relieve pressure from the umbilical cord. And there are several ways that you as a midwife, you need to relieve this pressure from the umbilical cord. Number one, we are trying to say, keep fingers inside the vagina to try to push the presending part off from the cord. And this one will assist you from relieving cord compression, which can cause actually fetal hypoxia. The other one, we are saying, raise the pelvic or the buttocks of the mother, so that you can also relieve pressure of the presending part on the umbilical cord. You can also use pillows. Pillows, you can put them on the mother's buttocks. And this position, you normally call it in nursing position, exaggerated seams position. Or you can adopt a knee chest position, so that you can be able to turn the gravitational force towards the diaphragm. So it means that the fetus is going back to the diaphragm. Or you can use the foot of the bed that can be able to rest. Sometimes we normally use what we call a bladder filling. We can also help in managing the cord prolapse, and we normally fill the bladder with around 500 to 700 of water using a 4-lips catheter, and this will normally assist in relieving this one. So by this one, we are trying to ask yourself, if this helps in relieving the pressure from the cord by elevating the presenting part. And normally, relieving this pressure of the umbilical cord, it's normally approximately around 2 centimeters above the ischial spines. That is where we normally relieve the pressure of the umbilical cord. Then we are saying the bladder should be drained if the mother must be taken for cesarean section. And in most cases, we are saying this mother is prepared for emergency cesarean section. But now this one, the emergency cesarean section will depend about on the cervical dilatation. Now we ask ourselves, is this mother in the BMOC facility? If she's in the BMOC facility, we need to transfer mother for CMOC facility. Now the management of this mother will depend on the cervical dilatation. If the cervix is fully dilated, sleep over the, they need to remove the cord, put the cord aside. Then they give the mother bilateral episiotomy to hasten the delivery. If it is not fully dilated, prepare mother for cesarean section. Bye bye.